Look in the mirror and notice your lip is just a bit puffy. Usually, we just brush it off, right? We assume it's a mild allergic reaction, maybe to a new chapstick or a rogue mosquito got us in our sleep. The swelling goes away in a day or two and we totally forget about it. But what happens when it doesn't? What if that seemingly harmless swelling returns, stays longer, and eventually never leaves? That's the reality for patients with the condition we're analyzing today. It's a situation where a local swelling is actually a massive clue pointing to a much deeper systemic mystery.
Now, this image really captures what we're dealing with. This is not just a temporary hive. Notice how the enlarged lip looks severely cracked and fissured. You can literally see the reddish-brown discoloration and scaling right across the mucosal surface. And what you can't see, but what the patient absolutely feels, is that this fissured lip becomes painful and actually takes on the consistency of firm rubber. We're talking about a persistent structural alteration of the tissue itself.
Here's our agenda for this explainer. First, the swelling mystery. 2. Two names, one condition. 3. Tracking the hidden causes. 4. Clinical signs and symptoms. 5. Ruling out the imposters. And finally, 6. Management and treatment.
Section 1. The swelling mystery. More than meets the eye.
So, the clinical definition of Cheilitis granulomatosa is quite simply a chronic swelling of the lip due to granulomatous inflammation. While from the outside it might just look like a simple fluid buildup, on a microscopic level, the normal architecture of the lip is actually being fundamentally altered. This whole process is driven by two main things: lymphedema, which is localized fluid retention and tissue swelling, paired with the presence of non-caseating granulomas right in the lamina propria. Your body's immune system is basically walling off what it thinks is an invader, and that leads to a literal physical restructuring of the lip tissue.
Section 2.
Really fascinating here is how the medical community categorizes the exact same physical symptom just based on its surrounding context. If a patient comes in with this granulomatous swelling confined entirely and exclusively to the lip, it's called cheilitis. But if that exact same lip swelling shows up alongside facial palsy and a fissured tongue, well, then it gets a completely different name: Melkerson-Rosenthal syndrome.
And that brings us to the famous Melkerson-Rosenthal syndrome triad: cheilitis, intermittent seventh nerve facial palsy, and a fissured tongue. Most experts actually regard cheilitis as just a monosymptomatic form of this broader syndrome. Basically, it's just the first or maybe the only symptom showing up. However, and this is where it gets tricky, the possibility remains that these might actually be two completely separate diseases just masquerading as one another.
Etiology. Despite all our modern medical advancements, the true cause remains unknown. Frustrating, right? Both for doctors and patients. But we do have some clues. We know genetics likely play a role, especially in Melkerson-Rosenthal syndrome, because we've actually seen siblings affected by it. Plus, even unaffected relatives sometimes present with a plicat or folded tongue right from birth. That strongly points to a genetic susceptibility running in the family line.
Beyond genetics, researchers have pinned down a few potential culprits and triggers. Dietary antigens and food additives are actually the most commonly identified causes when this presents as part of a broader orofacial granulomatosis. Sometimes, even simple contact antigens, like metals, are implicated. But arguably the most sinister potential link here is to underlying systemic organic diseases, specifically Crohn's disease and sarcoidosis. In those cases, the swollen lip is literally just the tip of the iceberg.
Section 4. Clinical signs. This disease is incredibly deceptive. The very first episode of swelling typically goes away completely within hours or maybe a few days. The patient thinks, great, I'm fine. But then the recurrences start. They can range from days to years apart. And with each recurrent attack, the swelling sticks around a little bit longer and slowly gets worse. Fast forward a few years and the swelling stops subsiding altogether. It becomes permanent. The upper lip is involved slightly more often than the lower, and it transforms into that firm, rubbery, painful state we talked about earlier. Occasionally, these attacks even come with fever, headaches, or visual disturbances.
But the lip is definitely not the only casualty. About 30% of patients end up developing facial palsy of the lower motor neuron type. This palsy might be intermittent at first, but it can eventually become permanent, and it can be unilateral or bilateral. What's really wild is that this facial paralysis can sometimes precede the lip swelling by months or even years, which absolutely throws off a quick diagnosis.
And check out this visual link. Alongside the severe cheilitis granulomatosa, between 20 to 40% of patients will also present with this deeply grooved, fissured tongue. The whole condition can also bring along a host of other strange clinical signs. Patients might lose their sense of taste, suffer from decreased salivary gland secretion, and even experience autonomic disturbances. Sometimes other cranial nerves, like the auditory or olfactory nerves, get affected too. It's a whole cascade of issues.
Oh, and here's another vital diagnostic clue. 50% of patients also present with enlarged regional lymph nodes. Though, to be fair, the enlargement is usually minimal. Section 5. Ruling out the imposters. The differential diagnosis.
So the investigation process is basically a masterclass in ruling out imposters. Step 1. Verify it's not just a localized reaction like a really bad insect bite, but then the search has to go systemic. To rule out sarcoidosis, doctors need to run a serum angiotensin converting enzyme test, take chest radioact oral symptoms, a gastrointestinal tract endoscopy and radiography might be completely necessary.
Now, if the clinical signs aren't enough, doctors have to look under the microscope. The histologic features are actually highly characteristic. They'll find a chronic inflammatory cell infiltrate, specifically peri- and peravascular aggregations of lymphocytes, plasma cells, and histiocytes. But the real smoking gun? Focal non-caseating granuloma formation featuring epithelioid cells and Langhans-type giant cells. The catch is, these exact microscopic findings are highly suggestive of sarcoidosis too. But right now, there just isn't quite enough evidence to definitively link the two diseases, so the mystery stays alive.
Section 6. Management and Treatment. Solving the case.
All right, let's talk about the management strategy, which is essentially a mix of prevention and conservative treatment. First up, doctors will often use patch tests to see if they can pinpoint a specific trigger, things like metals, food additives, or other oral antigens. If a sensitivity is found, the rule is strict avoidance. When the swelling does flare up, it's conservatively managed directly at the site using intralesional corticosteroid injections to fight that granulomatous inflammation. This is often paired with nonsteroidal anti-inflammatory drugs to give the patient some much-needed systemic relief.
So what starts as a seemingly benign swelling of the lip can totally unravel into this complex web of genetics, facial paralysis, and potential links to massive gastrointestinal or systemic inflammatory diseases. It really forces us to ask a profound question when we look in the mirror. Is a symptom ever just local? Or is the mouth, in all its complex pathology, actually a mirror reflecting the hidden health of your entire body? Definitely something to keep in mind the next time you notice something slightly off. Thanks for joining me for this explainer, and keep learning.